So thank you very much. The next session we are going to start coronary artery disease management update, and I would request the panel of experts to kindly take the chair. Major General Retired Azhar Mahmood Kiani, Major General Retired Farhan Tayyab, Professor Tahir Saghir, Professor Abidullah, Professor Javed Akbar Sial, Brigadier Asif Nadeem. I would request the first speaker, Professor Dr. Mansoor Ahmed, to kindly deliver his talk on chronic coronary syndrome.
Assalamu alaikum. It's wonderful being here. मेरा time अभी start नहीं हुआ. Number one, thank you all the generals, ladies and gentlemen. पहली चीज़ तो ये, there was too many comments in the last talk, तो मैं I'll take my time on that, on transplant. Number one, ईदी साहब की जब death हुई, तो do you know कि उनकी नमाज जनाजा किसी ने नहीं पढ़ाई? All the Maulvis actually refused कि इसने अपनी आंखें डोनेट कर दी हैं जो कि हराम है. तो आपकी फौज से मलीर से बुलाना पड़ा था मौलवी साहब को, उन्होंने नमाज जनाजा पढ़ाई. नंबर टू, ट्रांसप्लांट इज़ नॉट सच अ सिंपल स्टफ. ट्रांसप्लांट में बिकॉज आई वाज, जो यूके का फर्स्ट ट्रांसप्लांट हुआ था वो हमारा पेशेंट था. आई एम सॉरी आई एम टेकिंग टाइम बट आई थिंक इट्स वेरी इंपॉर्टेंट. इसमें आपके पास HLA टाइपिंग का बैंक होता है और जहाँ पर किसी की, जहाँ से डोनेटेड हार्ट मिलता है उसके टिश्यू मैचिंग होती है और फिर आप बुलाते हैं. तो यू हैव टू गो थ्रू लॉट्स ऑफ लॉजिस्टिक्स. हमारे यहाँ प्रेजेंट डे ट्रांसप्लांट जो हो रहा है ब्लड ग्रुप पे होता है जिसमें सक्सेस रेट इज़ नॉट दैट हाई. तो दैट इज़ नंबर वन. एंड फाइनली द ग्रेट ट्रांसप्लांट सर्जन Magdi Yaqub. I have never seen a standing ovation that I have seen for Magdi for anybody else ever. And Magdi said, I used to do bypasses and I was always stressful. Yeah, it's so difficult, this may happen, that may happen. When I did my first transplant, I had to wake myself up, yeah, there is no stress. Because you pick an organ, you stitch here, stitch there, and it's done. And then he said, when I did my first heart and lung transplant, I was still surprised, it was so simple. And when I did my heart, lung, and liver transplant, he said, literally, I picked up this thing from one frame, put it on the other frame, and tie it one end and the other end. So technically, surgery may be very simple, but I think it's the tissue matching and logistics which is not always so easy. Present day, heart transplant की waiting list is almost 6 to 8 years. और उसकी वजह यही है कि टिश्यू मैच करना is not always easy. Plus, in my time when I was in training, there were lots of accidents, क्योंकि ड्रिंकिंग ड्राइविंग पे बैन नहीं था. अब जब से ये हुआ है, एक्सीडेंट्स कम हो गए यंग लोगों के, प्लस एक्सीडेंट्स होते भी हैं तो ट्रीटमेंट इज़ सो गुड दैट मेजॉरिटी इज सेव्ड. तो आई थिंक देयर विल बी प्रॉब्लम्स, बट आई एम ग्लैड यू आर प्लानिंग इट. Whatever, we have to take a start. So I wanted to make these comments before I start my talk. Okay, now my time may start. Let's go. So
you already spent 3 minutes.
Yes, I told you कि my time. Okay, जितनी बातें करोगे मैं अपना इतना ही delay करूँगा time. Thank you. Sorry about that. Apologies. Okay, now this is the topic, chronic coronary syndrome. What is this, yaar? In 2013, it was called, ESC called it chronic stable angina. We all knew about stable angina and unstable long time ago. In 2019, they changed it to chronic coronary syndrome. Now what happened? Last year, the Americans came up with a new word, that is chronic coronary disease, CCD. So now we are talking about it. I'll go through both very rapidly. What is this, what is not? You all understand everything. So, oh dear, this doesn't, I can't read it myself. So anyway, suspected and established are somebody who is already known to have coronary disease. They are all chronic coronary syndromes, unless they become unstable or acute coronary syndrome. This may be LV dysfunction, heart failure, and all those things. My God. Now, I've just received this talk. Anyway, if the resting ECG is abnormal, you can assume that this patient has got chronic coronary disease, and you don't need to do a stress test on these people to diagnose this patient. Okay, echocardiography, we know wall motion abnormalities, LV dysfunctions, we should suspect coronary disease in those patients. I'll go rapidly because there are many slides, and I just have to do a little comparison between 2019 and 2023. Exercise ECG was class 1, level C. And of course, furthermore, stress echocardiography, spectra, or PET, or contrast echocardiography, or CMR. So coronary angiography was again class 1 in a certain group of patients where they needed. I'm just going to go, oh my God, yeah. Okay, management, it's more or less the same, not very big difference. Lifestyle, pharmacological, and revascularization, these are the basic theme of management of coronary disease. Lifestyle, I won't spend too much time on that. Diet pay, I think I always enjoy talking on diet because the kind of diet we prescribe to our patient, ki ye band, wo band, phika, ubla hua khana, for God's sake, if you look into the data, more people die on such a diet than they survive. They need nourishment. Calorie intake has to be there. Fat intake is mandatory. You cut down fat intake from 40% of your calorie in normal diet to 35%, and if you are very strict, to 30%. And you got to use oil which is rich in polyunsaturated fats or monosaturated fats. Okay, again, I think I'll move on to now 2023. I'll move. Here there is differences that ivabradine in ESC is part of the management, whereas I'll go through next. In ASC, this is class 3. Okay, so ranolazine is there. Trimetazine is not available in ACC or AHA. These are the difference between across the Atlantic. Aspirin is there. Anticoagulation, this is all the same. I'll just move on to statin again. Most of us do not prescribe high intensity statins. I wonder really why. People come to me when I give high dose statin. Many people will come back to me, ji फला doctor ने कम कर दिया, उसने इतना कर दिया, उसने कहा तुम्हें ये हो जाएगा, तुम्हें वो हो जाएगा, and he says body pains हो रहे हैं. Now when you explain to them the benefit of statin is the only group of drug which is proved to slow down or prevent the progression of the disease. This is the only drug, and once you explain it to the patient and once the patient understands, they stop complaining. And I usually follow a target of LDL of 50 or less, and people remain healthy even if it's 40 or even less than 40. Now, we come to this, they have described it as chronic coronary disease. Let's move on. It's the same thing. They are emphasizing on certain things, which is lifestyle mainly, diagnostic evaluation. Now, they recommend that diagnostic evaluation should be done only in those patients where there is symptomatic change or functional change. Otherwise, don't do any further tests, just carry on, follow up, and they advise follow up once a year at least. So it's more of the same thing, and you can actually do any kind of stress test or even angiogram if you think feasible. So it's all allowed as class 1. Okay, I won't spend time on that. Risk stratification you have to do before you decide to treat them. for long-term, they should have long-term planning, and that is where risk stratification is important. Okay. Now again, general approach, won't spend time on that. Now this is something which may not be available to us. There are 4, 5, 6, 7, 8, 9, 10 things. And in our part of the world, one person has to behave like 10 different people. So it's the physician alone. Your patient expect कि जी सारा काम डॉक्टर ने करना है, डाइट भी करना है, एक्सरसाइज भी बताना है, प्रोटोकॉल वगैरह. This is where a system is needed, which may be available to FIC, but I don't think anywhere else. And in fact, NICVD is trying to evolve this system. And I've seen they have rehab center as well as awareness sessions they perform. And in fact, preventive cardiology, they have developed a department. So team-based approach, this is, again, more or less repeat of the same thing. So many persons, you have to collaborate in your own mind. Nutrition, again, nutrition is very, very important. This is class 1 here, and this is where it says that they actually use lean protein. हम लोग कह देते हैं beef बंद, गोश्त बंद, सब कुछ बंद. Now, where do we get it? I don't know, because it's not science. They mention lean protein, that is meat without fat, lean meat. Of course, overall, we must cut down animal food intake and prefer vegetable origin diet, which is very true, but there is no indication कि should stop it altogether. तो उबला हुआ खाना, लौकी खिलाना, हमारे यहाँ तो कहते हैं कि सुन्नत भी है, और बेचारे मरीज का बड़ा बुरा हाल होता है. So this is again a very, very important part of my treatment that I advise, because if you do not feed them well, if they do not get enough nourishment, they are not going to act. They will be in bed, and lying in bed is very dangerous. Again, I would like to, I don't know if how many of you actually understand this thing. Since 1950, when after first myocardial infarction, 95% people were stand retired. And 30% of them used to die because bed rest was minimum 3 months. And during those 3 months, many people used to die. Most of them DVT and pulmonary embolism. And most of the time when we see people are going back to normal, 95% people go back to work, a lot of it, most of it is actually related to early ambulation. Mobility, exercise, and that's what keeps us going. Okay. Again, it says if you look at the, इधर है कुछ दिखाने का? Yeah. Yeah, pointer. If you look at that, they have actually classified as monosaturated as a very high content, although the Europeans do not mention monosaturated at all. They mention only polyunsaturated. So 20%, 10%, and saturated fat should be less than 10% of the total fat intake. That is the advice. Okay. Tobacco, of course, it must go. That includes vaping as well. Alcohol, there was a time in 80s and 90s when people used to say कि यार थोड़ा सा alcohol ले लिया करो अच्छा होता है. But now we know even a small quantity of alcohol is not good for myocardium. You may have your coronaries going for a while, but it does affect your myocardium. And this has been known since early 80s. So it is not recommended. Nobody will recommend. And if somebody is taking it, ask them to cut it down to whatever limit they have set. Well, of course, this was, when I came back to Pakistan, this was a no-go for a myocardial infarction. I wrote a rehabilitation program, and in that I had mentioned. So I remember late Syed Aslam साहब जब अपनी किताब लिख रहे थे तो उन्होंने कहा यार मुझे भेज दो तुमने बड़ा अच्छा लिखा है खास तौर से इस सब्जेक्ट पे तो I think इनकी किसी बुक में रेफरेंस दिया हुआ है इसका. Lipid management, I think here this is very important. To me, LDL of 50 or less in established coronary disease to prevent the progression of the disease. Because acute episodes, nobody knows when it happens, but this is the only group of drug which stabilizes. So much so that if it doesn't work, then you can add ezetimibe, and if that doesn't work, you can have PCSK9, and hopefully we'll have inclisiran very soon in our country, which has proved to be very beneficial. At least PCSK9 per data bhi hai. Inclisiran ka data is in the process, but whatever data it is there, it is safe. mRNA-based medicine, and all our new medicines are going to be mRNA-based. That is, so they'll be targeted specifically rather than affecting the whole system.
1 minute left.
Thank you. There won't be much. Very high risk, we all know about it. In fact, I want to raise a few questions after that, rather than talking about all this, because most of you do know, just the heading should tell you what I'm trying to say. There are a few questions that I have to put to you. This is another issue. Whenever I prescribe aspirin or clopidogrel, every other person would make it a combination of aspirin and clopidogrel both. I don't know why. It is not really needed in stable patients. You have to use it in acute post-acute coronary syndrome, in post-PCI, in post-CABG, but not after that. So we have to be very careful about dual antiplatelet beta blockers. We know the indications. Colchicine, yes, this is another. There was Colcott trial, and there are two other trials, because they are targeting inflammation these days, because we all have dealt with LDLs and everything, so inflammation is the only thing left, and colchicine has shown some benefit, and they've already included. So medical therapy, yeah. Yeah, look here, class 3 is ivabradine, whereas ESC says it is 1A, sorry, 2A, I beg your pardon, yeah. Refractory angina, no, revascularization is just the same. Whenever you do it, a lesion that needs to be done should be done. Prognostic lesions should be taken care of first, whereas non-prognostic lesions may be dealt with medically. Okay, revascularization के तो हम सारे expert हैं. So let's keep going. Okay, now my question is. नहीं पूछूं? Out of course, sir.
Yes, I think it's been a great presentation. The stable coronary artery disease is a whole subject of its own.
Yep.
So if everyone agrees, we will take the question towards the end, if that's okay.
Just
I've
one
said
short
enough.
comment. We can divide these patients into two groups. One of those who've been diagnosed, and the other first group which have not been diagnosed. जो कि diagnosed नहीं, उनके we can pray them, they should seek medical advice and get them diagnosed. And those who have been diagnosed should follow the principles of secondary prevention. That's it.
Thank you. इतना मैंने 10 मिनट खराब किया. But at the end of the day, all of you have been a very good audience. Thank you very much for not questioning.
Thank you, sir, for the nice talk. Next, I would request Professor Major General Retired Suhail Aziz to please give a talk on NSTEMI management advances and update.
Assalamu alaikum. Bismillahirrahmanirrahim. Everybody has been talking so much about time, so I'm going to be talking just about time. How do I start? Yeah. Okay, we all know about atheroma and what role it has in acute coronary syndrome, that there's the lipid core and you get a thrombus formation now, whether the occlusive or not, depends upon the size of it and how the flow across it happens. This is something we need to know, the different types of acute MIs. We tend not to look at them, but there's a type 2 myocardial infarction, which is secondary to ischemic imbalance. Now, you need to keep that in mind during the talk. So the reason for early invasive strategy is that we identify the cause and then we stabilize the plaque and prevent further ischemic episodes. We all know that acute MI is a very devastating event, and we all know that its immediate reperfusion is the established fact, and there's no doubt on that. Similarly, in non-STEMI, we also know that in appropriate patient, it's a well-established mode of treatment that we need to do early preservation. But the real question where there's a gap in the evidence, and that is what is the optimal timing of invasive strategy? That is controversial. And there's some evidence that high-risk patients benefit from early invasive strategy. Now, I was talking to Colonel Azhar, who just got promoted, and Mubarak once again. and Dr. Bilal, and they said कि सर आप एक slide में बस सारा lecture कर दें. So जिसने एक slide देखनी है वो उस आखिरी पैरे को देखे. Some evidence that high risk patients benefit from early invasive strategy. Now that is something to focus on. अगर आप कहते हैं तो मैं आगे भी चलता हूँ, वरना we can like stop here. चले. But the thing is that you must know that there's some data which is going on, and actually this is the only modality or mode of treatment in जिसमें ESC, AHA, and European, and they've all downclassed the evidence from 1A to 2A. And that has been basically because of some recent randomized trial, and even the trial was not evidence enough. The meta-analysis which they did in the discussion, that suggested that there's only a difference in the rate of recurrent ischemia with the randomized trial, and the time is still very controversial. So this gap in evidence concerns the optimal timing of angiography and revascularization. It needs further elaboration. And if you look at all the data, we'll find that data and the real life experience are very different in non-STEMI. And we're going to talk about that also. Some of you may know this guy. And when he was asked about the weapons of mass destruction, he said, we know there are knowns. These are things we know. We also know there are known unknowns. That is to say, we know there is something we do not know. There are also unknowns. The ones we don't know. And that kind of elaborates on the data we have on non-STEMI timing also. So all that, the reason being that all the clinical trials that we've seen and we've done so far, they all vary in their methodology, their results, the timing of the procedure. Some have been as short as 1 hour, some over 24 hours. The enrollment techniques have been very different. And of course, the primary endpoints have also varied in all of them. Look at them that, on the left, the pink shows some by very short, like 1 hour, when some want to 24 hours. The verdict is one trial along with Timax, which have been used very extensively in all the meta-analysis and evidence. And it used very early strategy of 12 hours. But this did not reduce the risk of composite endpoint of acute mortality, non-fatal MIs, admission, heart failure, so forth, except for those with a grace score of more than 140. Now that is another, keep this 140 number in mind because it's going to keep on cropping up. And all the trials, actually, just to summarize, because I have a feeling that we all go away from a lecture with just one lesson. And so that's the lesson that, except for the grace score of more than 140, an early non-STEMI probably doesn't have that much of a benefit. We'll talk more on this. They also did a meta-analysis of 8 randomized control trials, and they all showed no significant mortality reduction. However, the sub-analysis of the high-risk patients was done, and they found that those who had a high risk like diabetes, grace score more than 140, again that number, higher age, they tend to benefit from early revascularization. Timax was another trial. It was a pretty big trial of over 3,000 people. And that, again, in its 1/3 patients had a score of more than 150 grace score. And they're the people who benefited from early revascularization. And 2/3 had less than 130, 140 score. And they did not show benefit. So when you pull them together, the overall result was not positive. So they thought that this is not a conclusive trial. The sub-analysis showed that there's evidence. So they think it's just a hypothesis-generating trial. It doesn't answer. So there are many other trials, Riddle and the LIPA, and the abroad, and so on and so forth, and ISA-Cool. Let me show this. So all of them have been pooled together in this meta-analysis. And you can see that bulk of the evidence is on the side of early revascularization. And the numbers support that too. But they're not, p-value is not significant. So they can't be used as data also. So all the numbers suggest that early intervention has an advantage, but it didn't really match the p-value. The grace score of 140 subunit from Timac and Verdict, they both pulled together. and they showed that reduction in all-cause mortality associated with the early revascularization in a high baseline risk, again more than 140. And however, these both trials should be taken with some limitations which they had, because when they were being enrolled, they didn't have a very high, hence higher sensitivity troponin T. They didn't have the potent antiplatelets. They didn't have the guideline-directed medical therapy. So if they were done now, one wonders how useful would they be. So I'm going to rush through some of them now. So rapid STEMI was, non-STEMI was done to clarify this, but unfortunately, it could enroll only 18% of people. And in order to increase that, they included intermediate score people, and they found that the result was again diluted. So one of the conclusions they did was, because I'm rushed to slides because the time's short, that if you want to do a trial which will show early versus late revascularization, you need to enroll at least 70,000 people, which will be so difficult that it's going to be difficult to conduct that trial. So I'm going to rush through some of these trials. We talked about the conclusion of non-STEMI. And so look at the real life scenario. This is 748,000 people's registry where there was readmission database. And they found that intervention done on the first day had a mortality of 2.4%, and if done on 6th day, 10th day, it was 6.6%. So real life data is very different and significantly different than what the data shows. Even the 30-day mortality is very significant. So what's happening is that most patients who come have high risk of more than 140, but the European centers do not have the capacity to deal with all of them. In fact, in England, 96%, 94% who present have high 140 gray score, but only 16% were done early. So you need to restructure this whole system in order to cater for them, and can you really cater for them? So one of the conclusions which I think one needs to draw is that the optimal timing is still uncertain, and there's no difference in hard endpoints. Highest baseline is a predictor of future events. Subgroup analysis of the TIMAC and gray score suggested more than 40 suggest a reduction in composite ischemic outtime, and there's in early intervention, and there's no extra risk to the patient. Now that's a very important thing, that if you do a very early procedure, non-STEMI, there's no risk involved to the patient. So if there's no risk involved to the patient, there is no definitive early time. So what would be the incentive of doing a non-STEMI early in the admission? If you do it early, the real life data suggests that there is a remarkable advantage in mortality. But what happens is, if you do them early, you get an early bed space. I skipped the data in terms of time. You can reduce 2.5 to 3 days of admission time by doing early procedure. And that saves money also. So economically, it's very viable. So if the system can afford structurally to do an early procedure, non-STEMI, it's always a good idea to do an early STEMI because it will create beds for you, save money, and in real life data, registry data suggests it will save life also. Whereas randomized data, which I and Havisa were just discussing, does not show that unless it's a high score. So we need to apply the gray score to everybody and follow a lead from there and do it as early as possible. And that varies from one hospital to the other based on the logistics. Thank you very much.
Thank you, sir. I think that was a very elegant talk, as always. Any questions from the audience, please?
I would want comments rather than questions.
Okay, a comment. I think it's very clear that if we intervene early, we are not doing harm. That's what is important. So we need to continue our present practice. We don't need to change it. That as soon as we get a chance of these NSTEMI patients, we should subject them to angiogram and do intervention as needed. And those who are at high risk, they should be given priority. That's it.
Another comment I'd like to make is that non-STEMI is a very misunderstood concept.
You can call it
Now-
an acute coronary syndrome, you know.
Call it whatever.
Your topic name was NSTEMI, that's why I
Okay,
mentioned.
sure, of course. Non-STEMI is a very big misconception. Why do I say that? Now, if it is a non-STEMI, we expect it to be a intermittent clot. So why does the LV drop? Why does the non-STEMI drop the left ventricular function? You find so many people, they come with a history of chest pain, going for sometime, they come to you, see some T changes, you say this is non-STEMI. They're actually ST elevation MI which have come late and the ECGs have settled down and you label them as ST because there's no elevation and there's T changes. So they're actually evolving ST elevation MIs and they're still going ongoing chest pain. And there was a very wonderful Korean data that you must apply a door to balloon time on non-ST elevation MI. And his data suggested that if you apply a non-STEMI patients with door to balloon time, you'll be saving very significant lives. So we need to, I think, change terminology from, occlusive MI to non-occlusive, total wall thickness MI, non-thickness MI. But it's beyond the scope of this lecture to talk about it. But
Basically, we have known for decades that sometimes ECG changes may take up to 24 hours to come up. So, and many of these arteries in end STEMIs are totally occluded, and that's why it's there. And I think you're very right. We need to reevaluate our end STEMIs. How do you do that? I think we'll have to wait and see. But it's very, very significant.
you know
what you
how
have talked
many
about.
sensible people have tried to devise a trial for it and they could not complete it?
Yeah. Because it's an ECG finding, and ECGs may take a long
It's
time or
very
may never
difficult,
change.
very challenging to put these trials together.
We also have now cardiac biomarkers, you know. We have troponins which give a very early indication that the patient is having problem.
Professor Sohail,
We have some
very
scoring system as well, which are very helpful in
Yeah, the
deciding.
grace score, we must
Yeah.
apply the grace score, that's very important.
वो
Yeah.
बहुत अच्छा है, उससे आपको आइडिया हो जाता है कि आपने इंटरवीन करना है या नहीं करना।
you have defined
Excuse me, उस दिन आ रहा था कि NICVD के कई सेंटर्स हैं जो सब saying वो ECG नहीं करते, वो troponin करते हैं. I think that's very sensible. मतलब अगर पेन आई है तो troponin is going to dictate something. So
Sir,
ECG
pain-
of course acute हमें तो बता देगी.
वो तो बिल्कुल
But-
एक अलग चीज है। पेन
नहीं-
अगर है तो you have to intervene।
देखिए ECG जो हम करते हैं उसका तो गाइडलाइन है कि 10 मिनट के अंदर करनी है. But troponin is the one which has to be done.
Professor Sohail, very nicely presented topic, but I'm still slightly confused.
That makes all of us.
How you clarify and differentiate in a non-ST segment elevation MI patients who are at high risk and who are at low risk, number one. Number two, you said gray score of 140. Okay, but will you point out to some other tests which are very simple and a person over there in emergency can at that time immediately differentiate this is a high risk non-ST and this is a low risk or intermediate risk non-ST like troponins and BNPs and all other. Please, if you have.
Sir, I'm not being funny, लेकिन अगर वो कहते हैं समुद्र को कूजे में जमा कर दिया ना, तो अगर एक समुद्र कूजे में आ सकता है तो उसको रहना ही इधर चाहिए. It's not a bloody समुद्र, you know. So what I'm saying is कि देखिए जब आप गाइडलाइन को छोड़ देते हैं ना, किताब से हटते हैं तो फिर it's a educated guess. I mean I could not और हाँ फिर अपना हर logistic system बनाना है ना. अब जैसे होता है कि जी आपने हर ट्रायल में वो अंग्रेज़ों का सिस्टम है, वे 18 मिनट में अस्पताल से बंदा घर से अस्पताल पहुंच जाता है. यहाँ पे तो 1.5 दिन लग जाता है किसी बंदे को. तो आप जिनको आप स्टेज कर रहे होते हैं, आई मीन कैन यू लीव देम अलोन नोइंग कि वो 1.5 दिन लगा के फिर 20,000 की गाड़ी करा के आएगा. All those things matter. So जो आप पूछ रहे हैं, I wish I knew what the answer was. I don't even understand the question actually, but
So would like to just ask.
नहीं सर माफ करना. I'm very serious. I mean it's a very wonderful concept that you're saying, but very जी
Sir, just one question, sir. Thank you very much for a wonderful talk, sir. I just wanted to ask that, like you said that the high-risk patient, they should be intervened earlier. So we see many times in hospitals where the primary CAD facility is not available. So we have to transfer those patients immediately to the nearest tertiary care setting for those PCS. But the high-risk patients are those who are having hypotension or they are in failure. So transferring such patients to the nearest cath facility, it's also hazardous, considering the safety of the patient, and then, the staff, they're also, concerned that transferring such serious critical patients to that facility. So what should we do about them? Like, we should transfer them as such, or if we wait, then definitely mortality goes high. But if we transfer them in the same condition, so that transport is also a dilemma. So what's your say
देखिए
on this?
हमारी एम्बुलेंस पे तो ऊपर एक सायरन लगा होता है, एक ड्राइवर होता है, एक ऑक्सीजन सिलेंडर होता है ना. दैट्स नॉट एन एम्बुलेंस. लेडी डायना का जब हुआ था तो जो एम्बुलेंस आई थी उसमें 4O नेगेटिव ब्लड पड़े हुए थे. एंड जब ये ब्लू लाइन एम्बुलेंस चलती है वो हार्ट शोल्डर पे चलती है. इट्स एज एफिशिएंट एज इंटेंसिव केयर. सो जब हमारे पास वो लॉजिस्टिक्स नहीं है तो फिर इट्स फेयर गेम. लेकिन फौज में तो कहते हैं कि बंदा रास्ते में नहीं मरना चाहिए. Let him die where he is. Don't, if you send him, he dies, that's it, you're in trouble. So let him die in peace. आपका जो बंदा है ना, rather than, the family has to be taken into confidence, पूरा system बनेगा. So this is where Del Kiani and the administrative things will come.
So one more question, sir, please. So one more question, with your
Sir,
permission,
we'll
sir.
take
It was
one last
excellent academic talk. My question is this: after just having the sense-TEMI in front of you, you're just going to opt the early invasive strategy for the coronary angiogram, and most of the sense-TEMI usually present with the more than one vessel disease. So what will be your decision, just to go either with your naked eye decision, opting the culprit vessel, or you will just going to opt some other test? And we have to just clarify the answer with our averagely equipped labs in most of our part of our country. Second part of question is this, most of the centers are not been equipped with the low molecular weight heparin. So can we just replace the Dovax with the heparin with these NSTEMIs, because this is a real fact, the unavailability of the things. So please, your kind comments on this.
देखिए, very good question, लेकिन सबसे अच्छा सवाल किसी ने नहीं पूछा अभी तक. सबसे अच्छा सवाल ये है कि जो गाइडलाइन है वो कहती है कि आप कैथ करने से पहले उसको एंटीप्लेटलेट ना दें. बिकॉज वहां पे जिन्होंने गाइडलाइन बनाई है उनकी सर्जिकल टाइम इतनी तकड़ी है कि वो बंदे को कैथ लैब से उठा के थिएटर में ले जाएंगे. हमारा प्राइमरी पीसीआई में हु इज गोना सेंड समबडी टू द कैथ लैब, फ्रॉम कैथ लैब टू द ओटी? नो वन. सो और हमारे इतने ज्यादा एडहॉक्स होते हैं कि इनको आप गाइडलाइन फॉलो करें, एंटीप्लेटलेट ना दें, देन सी व्हाट हैपेंस. यू गॉट टू गिव. हम तो दे सकते हैं ना. सो देखिए, गाइडलाइन इज मेड बाय द फंड प्रोवाइडर. जिसने पैसे देने हैं, मसलन फरहान साहब का ड्राइवर आ गया, फरहान साहब कहते हैं मेरा पास ताल्लुक कोई नहीं है, लो जी इसको ट्रीट हिम लाइक अ पॉपर. बट वो कहते हैं यार बड़ा खानदानी बंदा है मेरा, इसको कुछ होना नहीं चाहिए, एंड देन थैंक यू फॉर द बिल. लेकिन अब फरहान साहब अगर उसके पैसे सारे दे रहे तो गाइडलाइन चेंज हो रही है. तो गाइडलाइन इज डिक्टेटेड बाय द फंड प्रोवाइडर. सो आई मीन जो अपना लोकल फैसिलिटी है, अगर DHQ फॉर एग्जांपल अगर है, उसमें डिसिप्लिन भी नहीं है, तो अब क्या कर सकते हैं? देखिए, डॉक्टर विल ओनली यूज द डिवाइस ही हैज. सो इट इज द सिस्टम. लाइक आई वाजंट जोकिंग व्हेन आई सेड कि मेडिसिन इज सच अ सीरियस बिजनेस, इट कांट बी लेफ्ट टू द डॉक्टर्स. हम लोग तो एक एंड मोटर न्यूरॉन के एंड पाथवे है ना, जो आएगा वो करेंगे. वी विल बी ब्लेम्ड फॉर एवरीथिंग कि हम तो आप. लेकिन प्लीज आप कीप योर हायर अप्स इन पिक्चर. इफ समथिंग गोज रॉन्ग, दे से आप बताते हम तो इसको अमेरिका भेज देते. आए दिन होता है कि छापा मारा उसने, उसका भी फ्री करा दिया, उसका फ्री कर दिया. व्हाट अबाउट द अदर 80 पीपल लाइंग इन द वार्ड, उनका फ्री कौन करेगा? सो ये वी आर मेड स्केपगोट्स. सो प्लीज लुक आफ्टर योरसेल्फ बेस्ड ऑन ए सिस्टम. या आप किसी बड़े बंदे से जारी लगा के रखें, जैसे सर बैठे हैं वहां पे, जय नजर क्या नहीं, ठीक है. मैंने तो इनके साथ जारी लगा के रखी है. नोबडी कम्स क्लोज टू मी. Yeah, and I get elected in elections also.
Thank you, sir, for your talk.
Aging.
Now I would request the next speaker, Professor Dr. Jabbar Ali, to give talk on complex PCI and high-risk PCI in indicated patients.
Indicated patients.
Indicated.
Assalamu alaikum, everybody. The talk that I am given is complex PCI and complex high-risk indicated intervention. This is a CHIP. It is relatively a new concept when PCI was started in early 70s or 80s, only the simple lesion would be done by the interventional cardiologist, and all the complex procedure would be referred to cardiac surgeon. So now the time is for surgery and intervention cardiology to get in the same sandbox. As far as the definition of complex PCI is concerned, there is no consensus, but this is derived from comparability and sensitivity analysis that define is if the lesion is more than multivessel PCI, more than 3 lesions, lesion length is more than 60 millimeter stent length, and lesion is more than 30. These are bifurcation CTOs. These are complex PCI. So in the beginning, as I said earlier, so now these patients are increasing number of CTOs, and all the complex PCIs are being done rather than being sent to the surgeon. So what is CHIP? It needs a specialized skills, both skill-wise as well as you have to be cognitively and mentally strong. As the age increases, the number of CHIP procedure will increase, not only because the age because of the age, but as the age increases, there is more complex lesion, more calcification. Most of the patients are post-CABG, and they are hemodynamically compromised. So the CHIP component actually consists of it has 3 components. Patient factors, this is comorbidity, surgical ineligibility. Then complicated heart disease for hemodynamically unstable patients, low EF. Then complex PCI. So all these 3 components has to be present. So there is, as I mentioned earlier, there was no consensus definition of CHIP. So they have, proposed different definition of CHIP. So this was the last, it is by the Japanese group who has proposed this new concept. This is what is definite CHIP. It consists of the complex PCI. PCI has to be complex. And both patient factor and complicated heart disease has to be present. If both are present, this is definite CHIP. If one of them, complex PCI plus one of them, then this is possible CHIP. The rest are non-CHIP. So this is the diagram which will help. Patient factors, frailty, active malignancy, liver cirrhosis, hemodialysis, etc. These are the patient factors. Then complicated heart disease, concomitant valvular heart disease, low EF, unstable hemodynamics, and complex PCI, left main, chronic brutal occlusion, if they need some atherectomies, orbital or rotational. So as we see, the CHIP, definite CHIP, this is a small number. Then the possible CHIP, it is double, but majority of the patients are non-CHIP. What determines the outcomes? The CHIP itself determines the outcomes. If you have CHIP patients, the odd ratio is 2, and others, if the patient is on immune suppressive drugs, unstable hemodynamics, and frailty. These will determine the outcome. Long-term outcomes, as we see, event-free survival. If the patient is definite CHIP, the long-term outcome is not good. If this possible CHIP, it is better than definite CHIP, but still not as non-CHIP. This is whether we need MCS or not. This was proposed by Italian Society of Interventional Cardiology, and it was being endorsed by Portuguese and Spanish Society. And they recommend that if there is unprotected left main or the Santa score is more than 33, then you can use MCS, basically MPELA. So now I will present a few cases. This was a 63-year-old lady, non-hypertensive, presented to us with unstable angina for 1 week. ECG shows STT changes, echo shows preserved EF. We did her CAD. We actually sent her to the surgeon, but the patient flatly and the family refused. As we can see, the osteality is total. There is another lesion in the OM which is also total. So we took the dual injections to identify the course of the CTO. It was a short CTO, osteal. We could cross it with pilot 200 easily, and we initially dilated with one O balloon. So this was the final result. So this patient, this was complex PCI. There was no patient factors or there was no adverse hemodynamics. So this was just a complex PCI. This is a 61-year-old, 61-year-old lady who was hypertensive, presented unstable angina. She had past history of MI, ECG show STT changes, echo show EF less than 30. So we did her CAD. Again, we sent this patient to Cabbage, but it was refused. So we planned, I have to rush. So we planned two-stent strategy, DK crush. We follow all the steps. So this was the final. So this patient was a case of possible chip because she has complex PCI, needed two-stent strategy. It has depressed LV function less than 40. This is a 87-year-old patient. He had MI 1 year back, unstable angina, and had a syncopal attack. STT changes on ECG, echo show EF of 26%. So this was his baseline angiography. As soon as we saw the patients, we immediately sent the patient to a surgeon. And what the surgeon say, they say medical therapy, but the patient was having continuous chest pain. He was seen by 2 surgeons. So we have to do, we planned him for high-risk PCI. We quickly dilated the left main. Right from the beginning, we took the pilot 200, so we can cross the mid-LED lesion that was CTO. We dilated sequentially initially with 1 and then 2, and then left main stenting. So his EF after 3 months was increased from 26 to 45 to 50. So this was a case of definite chip, complex PCI, patient factors, as well as complicated heart disease, low EF, frailty, 87-year-old. Otherwise, he was well built. And this is a 50-year-old lady. She was diabetic and had interior wall MIs few days back. And we sent this patient to a surgeon. But surgeon, again, because of low EF, she was refused. We started the procedure under the intra-aortic balloon pump because she had low blood pressure and LV was poor. We were having difficulty to track the stents downward. So we are doing now balloon anchoring. So this was the final, and she's still doing well. LV is almost the same, 35 to 40, but she's doing well. She can do or help. This is a case of definite shift. One last case. This was a 100-year-old. He had interior wall MI some year back, and then was having unstable angina and non-sustained VT. So otherwise, he was well built.
Jabbar, 1 minute left.
Okay, just few slides. So this was his CAD baseline angiogram, left main. We did a quick mini crush. So this was again a case of definite chip. So this was the slides that I took from, there was a conference in Korea, Complex Intervention 2023. Operator volume dictates the outcomes. If you have high volume operator, the complex PCI outcome is good. This was the question which was asked, IVUS versus OCT, DQ crush or DQ culottes. The best outcome which was seen if you are planning left main PCI was the operator volume. So take home message, KISS principle, keep it simple. If you, because sometimes the lesion is angiographically severe, if you do IFR, FFR, it may not be that significant. Don't beat your head against the wall dealing with calcium or CTOs, so you should have the right tools available. Maximize success. It means, for example, sometimes we can do it from radial, but it may be difficult from radial or with 6 French cats, so you have to be, don't beat your head. You can change the catheter to 7 French or you change the axis to femoral. Don't be a hero. This is very important. When we are resident, Professor Hafiz would say कि आप अकेले कैथ लैब में जो है जब तक 2 बंदे ना हो PCI ना करें. So it is very true for the complex PCI, the chip procedure, and it has been proven from data. Single-handedly done, mortality was high, complications were high. If there were 2 eyes and 2 brain, the outcomes were good. So if you need MCS, do use it. Because God does not think I am an intervention cardiologist. Thank you very much.
Thank you, Jabase, for some very good case and a great presentation. Floor is open for any comments from the panel or from the audience.
Excellent talk. I think we need to assess these patients, the patient and the lesion. If the patient is low risk and the lesion is low risk, then anybody can attempt it. Then there are patients who are high risk and the lesion is high risk. They should be done under supervision with an expert operator. Then the third, which is the definitive chip, high risk lesions in high risk patients, they should only be done at big centers with operators having very high volume, because it does matter.
Yes, sir. You are very right. So this concept was actually started in 2016 by Dr. Doshi, and they have a white paper in circulation. The reason behind, because we do see in our clinical practice, patients, angio is done. For example, once I saw a patient, 93-year-old, angio was done, and then he was advised CABG. So surgeon would not touch the patients. So you have to assess the patients first, whether, because sometimes malignancy, life expectancy is less, very low, 6 months or less than 6 months. So we don't have to be a hero in such a cases. But if otherwise indicated, we have to do something and give some hope for to these patients.
And secondly, you showed that IABP doesn't have mortality benefit, but recently the DANGER trial has, that was on the microaxial pump. It did demonstrate the patient can benefit from these pumps in cardiogenic shock. But the only thing was that they had a longer follow-up, about 180 days, as compared with the previous trials where the follow-up was limited about 30-40 days.
Sir, you are very right. The DANGER shock trial, but actually it was done on STEMI patient, while in CHIP, the patient or either chronic coronary syndrome patient that Mansoor Saab presented, or they are NSTEMI, high-risk NSTEMI. So STEMI and shock patient were excluded from whatever data we have on CHIP.
These tests can be generalized.
Yeah.
So I'm a cardiac surgeon. I just want to, I really don't want to take all the responsibilities that surgeon will not go and touch the patient and something like. I think the only contraindication of cardiac surgery is that if the patient don't wish to proceed for open heart or a major surgical intervention, it is a good concept. If we can give benefit to the patient, it should be proceeded. But I don't think so any surgeon is going to say no. We always welcome. The only thing is that the patient will be the first to entertain if they are willing to proceed for open heart or they are proceed for intervention or cardiology. It is the choice of the patient, not the surgeon. I think patient will be more to choose what treatment modality should be good for him or her. I don't think so. Surgeons will always welcome. The number of the interventions you show, they all can be very easily accommodated by a surgeon. I don't think so there is any contraindication of surgery. I think it is the patient choice to proceed for his or her. I don't think so. It is the...
You are absolutely right. जितने पेशेंट ये जो 4-5 केसेस मैंने दिखाए हैं, इट वाज रेफर टू सर्जन एंड अगर मैं आपको वो इट वाज अनएथिकल कि वो जो सर्जन्स की रिमार्क्स उस पे लिखे थी कि मेडिकल थेरेपी
Jabbar साहब, we should keep it very scientific this discussion ना कि this is not a patient's choice anymore, it's like a shared decision making.
Yes.
आपने पेशेंट को एजुकेट करना है, उसका नफा नुकसान समझाना है, and then you're gonna help him decide. And देखिए, there's an awesome trial, almost 10 years old. उस वक्त एंजियोप्लास्टी बहुत primitive थी. They took all those high-risk patients for surgery and they did surgery with angioplasty and they found that surgical limb had a better outcome. So देखिए, ये कहना कि surgeon would never so know, that's very noble, we say respect that. But देखिए, आपने आखिर में ये नहीं करना कि दिल चला दिया, बाकी सिस्टम का क्या होगा? We are responsible for the kidney, the outcome, the lung, the hospital stay, and it is not just the destiny, it is the journey which is also important. You have to have a smooth.
Take the patient with us.
Yeah. So talk about अभी it's scores है. Just follow the scores and I must tell जल नसीर बैठे कि जब इतना बड़ा सिस्टम होता है जैसे FIC है with so many patients, तो आप लोग अपना खुद स्कोर बना सकते हैं.
So the patient
Which would be effective for
first.
that when you know the predictors of bad outcome. आपके पास surgical एक पूरा database है. उसमें आप correlate करें with bad outcome.
Sir, it's our duty to inform each and everything. We have to talk about the predictors and everything, but the patient preference will come at the first, as according to the guidelines. Yes, sir.
मैं कह रहा हूँ कि आपको इतना बड़ा database है, आप उसमें से predictors निकाल के you can make your own score. So you have to be very scientific about this decision.
So I think it's a great discussion and can go on. We will call it a day today and we'll move on.
Thank you very much.
And now the request is to the panelists and to the audience that keep question answer session for at the end of the session. As we are running short of time, the next speaker is Dr. Chirag Hussain, and he will give a talk on reperfusion management strategies in STEMI.
ये स्लाइड यहाँ से होती है, ठीक. बिस्मिल्लाहिर्रहमानिर्रहीम. Respected panelists and dear colleagues, अस्सलाम वालेकुम. पहले तो मैं एक रिक्वेस्ट पहले से ही कर देता हूँ कि ये जो मेरा टॉपिक है बहुत ही इम्पोर्टेंट है. ये बहुत कम मेडिसिन में इंटरवेंशन है जो आपकी मोर्टेलिटी 50% रिड्यूस करती हैं, लेकिन यही है जो मैं आगे डिस्कस कर रहा हूँ. 50% मोर्टेलिटी रिडक्शन है इस स्ट्रेटजी के साथ, तो बाकी हैं लेकिन अभी तक डॉक्यूमेंट नहीं हुए जो मोर्टेलिटी रिडक्शन है अगर हम कॉम्प्लेक्स पीसीआई करते हैं या और रूटीन इलेक्टिव पीसीआई करते हैं. तो ये एक रिक्वेस्ट है, अगर 2-3 मिनट ज़्यादा हो जाए तो ये बिल ज़रा कम बजाइएगा. तो 1 मिनट तो बहुत ज़्यादा है ना सर, 3 दे दे सर, 3 दे दे, खैर है कोई बात. अब मैं शुरू कर देता हूँ. तो माय टॉपिक इज reperfusion strategy and ST elevation myocardial infarction. I will be talking about this topic under these 3 headings: reperfusion timeline, when to give thrombolytic and transfer patient to PCI capable center, how to combine thrombolytic and PCI, which is also called pharmaco-invasive strategy. So this is just new LVB is overwhelming sign of chronic cardiomyopathy, ischemic or non-ischemic, with a dilated or hypertrophied myocardium rather than an extensive acute infarction. That's why in 2020, European and American guideline is no longer considered LVB as equivalent to acute ST elevation myocardial infarction. So this is very important slide. The first hour of the presentation of acute ST elevation MI is called a golden hour. Golden hour thrombolytic are very effective for fresh thrombus. In the first hour, almost thrombolysis is almost equal to the primary PCI. 1 to 3 hour is still a good time zone, and you can save good percentage of myocardium in this time zone. Thrombolysis are still effective. 3 to 12 hours, most of the necrosis has already been occurred. Thrombolysis are less effective, PCI much more effective. And reperfusion therapy in this time period actually treat peri-infarct angina, reduces the adverse left ventricular remodeling and decrease the mortality. May save some myocardium, mainly if pre-infarct angina or if artery partially recanalized or they have pre-existing collaterals. 12 to 24 hour piece thrombolytic are ineffective, PCI is somewhat effective. What is the patency rate of thrombolysis? TV2 to 3 flow can be achieved in 70 to 75% of these cases, and even more than 90% if they present in the first hour. There is some adverse effect of thrombolytic, most common is intracranial bleed, that occur in about 1% of these cases, and 15 to 30% of those who thrombolize have recurrent MI or recurrent myocardial ischemia. The superiority of PCI over fibrinolysis widen as the presentation is more delay beyond 3 hours, and that has been shown in this graph. If you see, the result is almost equal of thrombolysis in primary PCI in the first 3 hours, but beyond 3 hours, there is a drop, a drastic drop in the fibrinolytic therapy benefit, while the benefit of primary PCI beyond 3 hours is gradually decreased. Superiority of PCI over fibrinolysis widen. Emergent reperfusion with PCI or fibrinolysis, that's very important. Presentation within 12 hours of symptom onset or up to 24 hours for PCI, but up to 48 hours according to the ECC. If there is a persistent ST elevation in more than 2 or 2 contiguous lead, or if there is ST depression that is isolated, or if there is more prominent NV1 to V3, so PCI or thrombolysis are class 1 indication in the first 12 hours. Beyond 12 hours, PCI is class 2A indication in these patients according to the ECC, and class 1 indication according to the EAC. This apply even if chest pain has been resolved as long as the STs are up beyond the cut point or more than less than 24 hours. PCI preferred if the door to balloon time is less than 90 minutes for the patient who are presenting to the PCI capable center, and if the door to balloon time should be less than 120 if patient is presenting to PCI non-capable center. Patient presenting more than 24 hours and more than 48 hours according to the EAC after symptom onset generally do not have an indication for angioplasty. That is on the basis of occluded artery trial. That trial was published back in 2008, but still is respected because of its design and its result. Emergent PCI is still indicated in these patients who presented more than 24 hours if they have persistent ischemic symptom, or if they have cardiogenic shock, or if they have heart failure, or if the onset of symptom is not clear. So you may do PCI in these patients. When to give fibrinolytic to STEMI patient presenting to non-PCI hospital who are getting transferred to PCI center. 3 मिनट रहते हैं, बहुत कम रह गए. अच्छा, primary PCI superior to LATIC according to these trials started from early, late, mid-90s, that is PAMI, Dynami, and meta-analysis of 23 randomized trials have documented the efficacy of primary PCI, superiority of primary PCI over the fibrinolytic therapy. However, this depends upon the door to balloon time. If door to balloon time less than 120, PCI. If door to balloon time more than 120, consider thrombolytic mainly if the patient is less than 3 hours, and also consider the factor which argue against the lytic therapy. That is, if STEMI presentation is more than 3 hours, low risk patient, high risk patient is those who are anterior MI, those who have cardiac failure, and if age is more than 75-year age. And if the ECG changes are subtle, just ST elevation, which are just fulfilling the criteria for MI, they should have reperfusion must. First R is golden R for lytic that reduces the mortality 50% in this patient. In 1 to 3 R, 30 to 40% reduction in mortality. Time of presentation less than 2 to 3 hours make lytic comparable option to primary PCI as it is very effective in lysing thrombus. Uski tension hai mana time ki. Thrombus as that have been documented in PRAC2, CAPTAM, STREAM trial. These the trials which have documented that if presenter is earlier, then the result will be almost equal. STREAM trial, not go into the detail of this trial. STREAM may be seen as a lytic success in those who present as door to balloon was still decent. That is the sub-study of Horizon and Cadillac. They documented that if the door to balloon time is more than 90, that worsen the situation, worsen the outcome, especially in those who are early presenter, less than 1.5 hour, but not in late presenter. For patient presenting with more than 3 hours, or if they are high risk, do not accept any delay and keep in mind the effectiveness of lytic in this time period. Give thrombolytic and transfer for PCI. For presenter more than 3 hours in low risk, this against the lytic, transfer for PCI. But these are a few contraindications, you all know about that, but I will just mention the most important, that is if they have a ischemic stroke within 3 months, except if they have acute stroke within 4 to 4.5 hours. Unresponsive, uncontrolled hypertension in those who have surgery within 3 hours, within 3 weeks, or internal bleed within 3 to 4 weeks, and oral anticoagulants. Once you have decided to give fibrinolytic therapy because of expected delay, when do you do PCI after fibrinolysis? That is a two types. Rescue PCI hai, agar failed thrombolytic therapy hai, a patient develop cardiogenic shock, heart failure, rescue PCI regardless of the onset of the time since onset. And routine early PCI, this is also called pharmacoinvasive therapy. The pharmacoinvasive strategy, 2 to 24 hours of thrombolysis was associated with decreased recurrent MI and similar outcome to a timely primary PCI. And PCI so soon after lytic is safe with no increase in major or moderate bleeding risk. Why? Because of the short pharmacokinetic and short pharmacodynamic effect of thrombin-specific thrombolytic, which unfortunately, at least मेरे सूबे में तो उसकी अवेलेबिलिटी बहुत कम है और इसकी इफेक्ट यह है कि they will affect just plasminogen present in the thrombus, which they convert into plasmin, which then degrade the thrombus-bound fibrin. And these are the various available thrombolytic agent, and we just have streptokinase rarely. Before transfer, all patients should receive aspirin, clopidogrel 300 milligram, not 600 milligram, within the 24 hour of lytic therapy. टाइम खत्म है वरना ये केसेस में प्रेजेंट करता है. चलो आप पूछें उसके बारे में आगे बात करते हैं. थैंक यू जी. इम्पोर्टेंट है, पूछें. वो मैं फिर कहता हूँ अगर सर इजाजत हो तो सर वो मैं अभी एक
So we are running short of time by 50 minutes.
सर एक जवाहर साहब.
So we have the panel has decided there are no questions and no comments.
Sir,
we just have the lectures.
Sir, just
okay for your sake only.
जवाहर साहब अभी इसने पेशेंट प्रेजेंट किया है, वो शायद मैं अगर मैं गलत नहीं हूँ तो वो कह रहा था कि 2 days पहले इसको MI हुआ था और वो जबाराली उसको इंटरवीन कर रहे थे. तो before 48 hour, after 48 hour according to EAC and after 24 hour according to the ACC, this intervention in angioplasty is not recommended if there is no chest pain, if they are not in heart failure, if they are not in. So, but even that is for those because they are using fibrin specific thrombolytic. We are using streptokinase. And streptokinase half-life is about 36 hours. And thrombin specific thrombolytic, uski half-life less than 2 hours hai. वो तो स्टडीज उसी पे हुए हैं. अगर हम अपने एनवायरनमेंट में स्टडी करें तो शायद हम तो एक हफ्ते में भी रिकमेंड न कर लें. तो ये बताना था. थैंक यू.
Thank you, sir, for your talk. The next speaker is Professor Dr. Akhtar Ali Bandesha, and he would give a talk on CTO PCI.
Bismillahirrahmanirrahim. My topic is CTO. Actually, it comes under the umbrella of CHIP most of the time. And as the discussion was being done in a previous talk, that the surgeons, they like to do complex surgeries as well. The volume of the patients is so much that the current number of surgeons probably they cannot handle every patient who is destined for surgery, because in every hospital at least 30, 40, 50 patients are being angiography daily in major centers, and how many surgeons are there who can operate upon at least 50% or 30% of them. So the complex angioplasties, they will remain there. CTOs, they are diagnosed in around 16 to 20% patients with coronary artery disease undergoing angiography, and the procedure volume has increased from 2.7% in 2010 to 4.5% in 2017. So, and the success rate is also increasing with the passage of time, with newer techniques and technologies available for the CTO. The main indication of CTO PCA is symptom relief. Meticulous pre-procedural planning and systematic crossing attempts are recommended to optimize CTO PCA success rates. Intravascular imaging can facilitate CTO recanalization and improve long-term outcomes according to the newer guidelines. A systematic approach to complications can minimize their adverse effects. So basically, I will be talking about these three things in next few slides. How can we plan a CTO? How can newer devices like IVAS and every other devices, they can help in more success in the CTO intervention, and how can we minimize the complications associated with the CTO intervention. So meticulous planning, look at the angiogram, look at the prior films as well. If CT angiography is available, that will also help you in planning what strategy and what type of procedure you will be going with this. And this will result in less contrast and radiation and less fatigue to the patient and operator both. And we must check the viability and ischemia both, so that we must know before we embark upon that are we giving any benefit to patients or not. And time to talk with the patient and family, this because it's a complex procedure, so it should be discussed in detail with the patient and its his or her family, because of the procedure cost, the complications associated with it, failure associated with it, and all those things. So if they know from day one that this is a complex procedure, the things will be easier for the operator and the team. So study the lesion. We all know that proximal vessel tortuosity which will make things more complex. So is it tortuous or not? The proximal cap is ambiguous or clear. It is tapered or blunt. Side branches are there or not, and how much calcification proximally as well as in the lesion is there. study the lesion segment, CTO segment length, how much it is, the segment calcification, that will also determine how the things are difficult for the procedure. And how about the artery after the CTO, the caliber and quality of the distal vessel, is there any bifurcation or not? Is there any prior bypass graft insertion site or not? We must be looking all these things. Quality of the collaterals, it's also important. What type of, we all know that which collaterals they are preferred, the bypass graft first one, and then septal, and then epicardial. So what is their size and all that? And are they tortuous or not? How much dominant they are, their angle and location at the anti side, it's also important, so that you may assume whether your wire with the retrograde approach will be going into this into the main vessel on which side. So this is Warner classification. I will not be going into the details. JSCTO score we all know, and the less the JSCTO score, the more successful the wiring is. So it's important. So this is another CTO score. And this will also will help you in determining how much difficult this case will be for you. And anticoagulation during the PCI, if it is antegrade approach, more than 60 seconds actually, and if it is retrograde, then 350 should be the target. Double axis and dual injection, low magnification should be used. Inject donor vessel first, wait 1 to 2 seconds before injecting CTO vessel. No panic should be done while you are giving injections, and cine until the contrast clears. So that will help you in seeing clearly the proximal as well as the distal vessel. And the different wiring strategies, they are antegrade wiring and retrograde wiring. Integrate, they are simple, and then dissection and re-entry and retrograde is also like that. This is a hybrid CTO crossing algorithm where you must see with the dual injection whether there is a ambiguous proximal cap or not, poor distal target or not, appropriate interventional collaterals are there or not, and if it all are there, then retrograde approach is preferred. If it is not like that, the antegrade approach will be preferred. And if lesion length is less than 20 millimeter, then antegrade wiring is preferred. And if it is more than that, then antegrade dissection and re-entry is preferred. And then different catheters you can use, control stingray catheters or wire-based loss strategy or like that. And if retrograde approach, then retrograde true lumen puncture or retrograde dissection and re-entry accordingly. This is another Asia-Pacific society algorithm where they use this IVUS guided. Actually, the rest of the things they are as they are with the previous system, but they use IVUS to see the lesion and help in CTO. Wire selection and escalation start with polymer jacketed wire with soft tip, like Fielder XT or Fighter, and then you can proceed to Gaia second or Pilot 200, and then proceed to stiffer wires like Confianza or Hornet, all those. Methods for solving proximal cap ambiguity. IVUS guided entry of proximal cap, move the cap techniques, antegrade, dissection and re-entry, retrograde approaches. These are different things with you can solve the proximal cap ambiguity. Move the cap techniques, power knuckle technique, balloon assisted subintimal entry base technique, or side base technique, or dual lumen microcatheter and all those. So these are different types of techniques which you can use in CTO handling. And this is about the power knuckle, where a balloon is being used to fix the microcatheter so that you can apply more force on the wire and can cross the lesion. And balloon assisted base technique, actually, here you are using the balloon. And side balloon technique, in a side branch, actually, you are using the balloon and trying to make the procedure more successful. And dual lumen microcatheter, you can use one for the wire and one for the balloon, or the second wire in the side branch. And then the Corlino method, which you give injections, small volume of injection, contacts, and you can see you can go into the proper channel. Scratch and go technique, these are different techniques. Antegrader wire escalation, true lumen crossing, subintimal crossing or exit and all that. And retrograde approaches, we just touched it. And this is updated algorithm, which is similar. It's very, you can read it actually yourself. And role of IVUS, I'm not going to go into its detail, but it is being used and it's a good thing. IVUS guided puncture in case of proximal cave, evaluation interplaque, and I will not be the complications. There are a number of complications. I will not go into details, but we can reduce these complications. Thank you very much.
Sir, thank you for your talk. Next talk is on left main PCI in Pakistan. It would be given by Professor Dr. Nasir Samol.
Bismillah ar-Rahman ar-Rahim. I'll be discussing left mainstem PCI evidence and practice. Now, left mainstem disease is found to be in 3 to 5% of patients undergoing coronary angiography. And patients with LMS disease have a high morbidity and mortality because of the large myocardium at risk. Most of the patients of LMS disease are treated with cabbage. Syntax trial subgroup analysis showed the PCI is a viable option in left main stem disease patients. Now, this is the percentage distribution of involvement of different parts of the left main stem, and it is most common at the bifurcation, which is 66%. Now, bifurcation lesions are divided into true bifurcation and non-true bifurcation, depending upon whether the main, proximal main and the side branch have more than 50% stenosis or not. These are various different classifications which you all know very well. And Medina classification is the most commonly used classification, and in Medina classification, as you know, a number is assigned to, number 0 or 1 is assigned to lesions. If it is more than 50%, it is 1. If it is less than 50%, that is 0. And broadly, there are 2 bifurcation strategies, as has already been discussed: provisional and two-strand strategy. And these are the various two-strand strategies which you are well aware of. According to the Syntax trial, cabbage resulted in a fewer major CV events compared with PCI among patients with triple vessel coronary artery disease or left main stem disease. The Syntax trial, the scoring has been divided into 3 groups, which is low syntax, intermediate, and high syntax score. And the cutoff is 22, 23 to 32, and more than 33. This was a trial, recombat trial, which showed that at 10 years, there was no significant difference in MACE between two groups, which was CABG versus left mainstem PCI, although the risk of repeat procedures was more in case of PCI group. The AXL trial, which is a landmark trial, it showed that the left main coronary artery disease patients with low or intermediate syntax, they are good for PCI. And again, there was more incidence of revascularization in the PCI group. And this is, again, the outcome of the AXL. Similarly, Noble trial, another landmark trial, in which there was a composite of all-cause mortality in repeat coronary revascularization with stroke, and occurred in 29% patients treated with PCI and 19% patients treated with CABG. These are the different meta-analyses which had been done from 2009 to 2021, and various different trials have been done in patients with high-risk anatomy with LMS disease and multivessel disease. CABG is, of course, has the clear advantage. The patients with low or intermediate syntax score, they can be taken for PCI. This is the definition of complex bifurcation criteria. There are major and minor criteria, and there are two major. If the lesion is more than 10 millimeter and the stenosis is more than 70% in case of left mainstem, and more than 90% in case of non-left mainstem disease. A complex bifurcation is defined as either two major or one major and two minor criteria. These are the various trials which have compared the provisional versus two-stent strategy, excluding the last one, which is Nordic 2. And in almost all these trials, the provisional strategy showed better outcome. These are few more trials comparing provisional versus two-stent strategy, and they have been done till 2021. Now, there are certain features which favor provisional strategy, which are, for example, small-sized circumflex, insignificant disease at the ostium of the circumflex, small length of the lesion of the circumflex at the ostium, right dominant system, and a wide angle between LAD and the circumflex. Now I'll present a case, a 76 years old gentleman, Canadian fidelity class 5, hypertensive, smoker, labs unremarkable, presented with non-ST elevation MI. And this was his angiogram. This shows disease at the distal end of the left main, including the osteoproximal LAD as well as circumflex. And you can see the various views. The right coronary artery is essentially normal. There is no critical disease. His syntax score was 26. And as far as syntax 2 is concerned, there was a PCI, 4-year mortality for PCI was 14%, and 4-year mortality for CABG was 20%. And his Euro score was 10.19%. And here's the indication for the use of intravascular imaging, which is IVUS. It is class 2A indication. Now, IVUS helps us in making the decision about the luminal size, the plaque distribution, plaque characterization, stent sizing, and the length of the disease. So it is a very helpful modality, and I think everybody believes that it should be used in all left mainstem PCI. Heart team meeting was done. Actually, patient was advised CABG, but the Patient family were counseled thoroughly for that the cabbage is a superior option. However, they declined cabbage and they opted for a PCI. And a 7 French sheathless guide catheter was taken, and both LED and circumflex were wired. LED was pre-dilated with 315 balloon, and circumflex with 2.75 NC balloon, and left main stem with 3.5 12 NC. IVUS was done in both LED as well as circumflex, and these are the runs of IVUS. So you can see a lot of atheroma, critical disease, and some calcium. So we proceeded with the procedure, and we stented, we parked a balloon in the LED and placed the stent in left main to circumflex, deployed that, and crushed with that 3.5 12 NC balloon. And then step crush was done with 4.58. I will go through quickly as the bell has rung. And dot was done. We did, this was basically DK crush technique, and we did all the steps. And I'll be quickly going through these steps. So this was the stenting of the LED. This was pot done with 508 NC balloon, recrossing and opening the studs. And this was the final result. Final IVUS run was done, and final pot again was done with 508 balloon. And that was the final result. Recovery was uneventful, patient stayed well, there was no complication, and he was discharged next day. This is the data of FIC. In 2023, we did 123 cases of left main stem PCI, and 93 cases were done with provisional strategy, whereas 27 cases were done with DK crush technique, and 3 cases were done with other techniques. And on the right side is total number 42, and then DK crush 28, and other techniques 13, and that is the data of this year till June. Thank you very much.
Thank you, sir, for your talk. Next speaker is Professor Dr. Sher Bahadur, and he will give a talk on bifurcation, PCI, procedural techniques, steps of different techniques.
Slide show nahi. Bismillahirrahmanirrahim. I am thankful to the organizer for inviting me for this talk. I will talk on the procedural strips and bifurcation techniques. You know that the true bifurcation is the one which the side branch has more than 50% disease and the side branch has more than 2.5 millimeter in diameter. You know the definition criteria. Based on this criteria, we divide the true bifurcation into simple true and complex true. The reason is, if there is simple true, we go for provisional stenting, and a complex true, then we go for upfront two-stent strategy. There are trial, very famous Nordic, Cactus, and BBC one, which showed that the provisional strategy is the same as that of the plain two-stent strategy, but these were the old trial, and those era, the stent, the drug-eluting stent was the first generation, and in these trial, the true bifurcation was not deal. The non-true bifurcation, yes, it is true. Evidence is cross-Korean trial in Nordic that they leave it alone strategy, that don't touch the side branch. The output was the same with provisional stenting. And other trial for the true bifurcation like Perfect and Lipman trial, EBC, MAN, DK Crush, they proved that the two-stent strategy is the same as provisional stenting. But again, these trials were not including the complex true bifurcation. The complex true bifurcation were included in the definition 2 trial and DK Crush trial, DK Crush 5 complex group, and they proved that the two-stent strategy is better than the single stent strategy. Coming to the steps, and bifurcations part is the important step because we select the stent according to the distal main vessels. So the proximal vessel is undersized to approximate it. We do port. It reduce the accidental abdominal wiring as well as it open the strut at the ostium of the side branch, so rewiring is easy. We should know the predictor of losing of a side branch and these bifurcation PCI. So if the bifurcation core stenosis is more or the ostium of the side branch stenosis is more or the ratio between the main vessel and the side branch is more than 2, or if there is a less than T3 before putting a stents, then it means losing of a side branch is high. For rewiring, we should take help of the pre-shaped wire, dual lumen microcatheter, angle microcatheters, deflectable microcatheters, and bifurcation. There is nowadays very famous JSKBT. The various modification is available. The gel balloon, balloon stent kissing, semi-inflated balloon, semi-inflated kissing balloon technique. So to start the step, if there is a simple two bifurcation, we should start with the provisional stenting. The steps are wire both branches and stent the main vessel to apart. If the result is ideal, the procedure is ended. If there is dissection and the side branch is less than T3 flow or the ostium of the side branch is stenosed, then we should go further step. We criss-cross the wires and do the KBI, kissing balloon inflation, followed by a part. If the result is optimal, the procedure will end. If there is indication for stenting of the side branch, then we should keep this algorithm in mind. So if the side branch is having 90 degree, then we should go for T-stenting. If the angle is 90 to 70, then tape technique. And if the angle is less than 70, then Coulard technique. But if the side branch and main vessel are not equal in diameter, then we should go for internal crush or reverse crush. And if we are unable to cross to the side branch, then we can crush the proximal main vessel still and can do the inverted DK crush. If we are going for the upfront two-stent strategy, then the same, but here we will start from the side branch. So the names are inverted Coulard, inverted tape, and inverted T, and the DK crush. So just if the provisional stenting, there is an indication for stenting of the side branch. If the angle is 90, we will put the stent at the ostium of the side branch, and then we'll balloon with nominal pressure, then we'll remove balloon proximally, and we'll go with high pressure. This is to optimize the ostium of the side branch. Then we'll do KBI, and then port, and the procedure will end. In case we put the side branch stent to distally, so we will cover with a third stent, and if we put the stent to proximally, then we will convert into the Coulard technique. And suppose 1 to 2 millimeter is in the proximal vessel, so internal crush will occur, and then we will proceed with the internal crush. The same technique is in the T-stenting, but here if the angle is less than 90 and more than 70, so we will go with the tape. So we have already done the main vessel, and we will stent the side branch with the tape. Tape means we will produce the ostium of the stent and the side branch 1 to 2 millimeter in the main vessels. Just concentrate on this. There was importance of KBI, that is kissing balloon inflations. If there is no kiss, just see the MHA. This is what the stent looks like at the ostium of the side branch. When the first kiss was introduced in the classical crush, then this is what the ostium of the side branch looked like. When two kiss was done in the DK crush, then the ostium of the side branch is very clear, so the struts are away from the carina. So that's why this double kissing was incorporated in the technique that is DK crush, DK Coulart, and DKT. That is the balloon-assisted double kissing technique. So coming to the inverted Coulart, we will start from the side branch, and after putting a stent in the side branch, we will do a port. After port, we will wire this stent again, and then we will put a stent in the main vessels and will dilate it, followed by a port. After port, we will do KBI and port again, and so the procedure will end. Coming to the DK crash, the first stent, so we will wire both branches, then pre-dilatation of both branches, then ballooning, then we will put a stent in the side branch. Here the protrusion will be just 2 millimeters into the main vessel. Then we will crush this with a balloon. This balloon size should be according to the distal main vessels. If this is incomplete crush, then we will take a balloon according to the proximal main vessels, and after crushing, we will wire the side branch again with and then small balloon, then a large balloon, and then we will do KBI. So coming to the balloon-assisted DKT stenting, this is the same like T stenting, but here while putting a stent in the side branch, we will take help of a balloon. Balloon is inflated for optimal positioning of the side branch stents. Then stent is deployed and the balloon is deflated again. After this, we will do KBI, and after KBI, we will pass a stent in the main vessels, and with the help of a balloon which is already there in the side branch, then we will do a port, KBI, followed by a port. It is the same like balloon-assisted DKT stenting, but if the angle is narrow, we have to put the side branch stent 1 to 2 millimeter in the main vessel. The remaining steps are the same. Coming to the crush technique, initially concentrate on the first line. Initially there was a classic crush in which you have to protrude your stent and the main vessel 4 to 5 millimeter. So position the side branch stent and the main vessel stent, then deploy the stent in the side branch and crush it with the stent and the main vessels. So the outcome was not good, so that a kiss was added, that is KBI was added. So the classic crush with the KBI is the same like classic crush, but here the KBI was added. Then there was a problem crossing side branch wire into a side branch. So the mini crush technique was emerged, and again it is with the 7-port guiding catheters. So here the steps are the same like classic crush with KBI, but before KBI there was a port. So in the remaining technique there was a port, kiss, port. The reason is you have to do port to cross a wire into a side branch, and then after KBI there is a proximal stent deformation, so to correct that you will do port again. The mini crush technique, the 6-French guiding is the same like mini crush with 7 French, but here instead of stent and the main vessel, you will put a balloon for crushing. The remaining steps are the same. The DK crush I already described. There are 2 kisses. First kiss after crushing of the stent, and the last port, kiss port. The nano crush is the same like mini crush, but here you will protrude the side branch stent 0.5 to 1 millimeter. This slide shows that among all these techniques, the DK crush was proved to be superior over classic crush. It is proved in the DK crush 1 trial, and the remaining all mentioned trial, the DK crush proved to be superior over provisional T stenting, Coulart, and provisional stenting. This is why the DK crush was considered to be the class 2B indication. It was preferred with the T stenting technique in case of LMS. This slide shows that the 2 stent techniques are superior over 1 stent technique, but in this definition 2 trial and major. This is the last slide.
Okay, thank you.
Okay, so and the majority and the 78% of the cases the DK crush was used. Okay, thank you.
Thank you so much. Thank you.
Thank you, sir, for your talk. Now the next talk would be given by Professor Dr. Asim Javed on role of mechanical thrombectomy in pulmonary embolism.
Bismillah ar-Rahman ar-Rahim. So we want to switch gears. I know I'm the last man standing between you and the lunch,
But I think I take this opportunity as we've got all the leaders in interventional cardiology sitting here, all the heads of institutes, and I think this is a subject that we really need to focus on. The reason being, we all know that pulmonary embolism is the third commonest cause of death in cardiovascular deaths after STEMI, acute stroke, and third one is pulmonary embolism. And the paradigm is really shifting in how to treat these patients. I'm going to skip a few slides and skip a few statistics in the interest of time. So I'm sure we all have experienced the same situation in the ICU where we have high risk or intermediate high risk pulmonary embolism patients, and we treat them with lytics, we give them anticoagulation, and what next? So we are waiting for these patients, and it's frustrating. We don't have anything else to offer to these patients. But as I said, the paradigm has changed. We are good at reducing mortality. So the mortality of TAVI has come down to less than 1%. Mortality of STEMI without cardiogenic shock is less than 1%. Mortality of high-risk pulmonary embolism is still 63%. We all know how to define intermediate high. So if we have three criteria, one is the blood pressure. If that is low, if the cardiac biomarkers are raised and RV dysfunction is there, it's a high-risk P. If the blood pressure is still stable and the other two are abnormal, then it's a intermediate to high-risk patient. We've got scoring systems. We've got PESI score. Most of us see these patients in PESI score 4 or 5, and we know that their mortality is around 25%. Another way of looking at these patients, this is BOVA score. So if the patient has a blood pressure of more than 100 millimeters systolic, but he has RV dysfunction, he has raised biomarkers, he has tachycardia, the mortality at 30 days goes up to 42%. It's not only about mortality with pulmonary embolism. Even if we help these patients to survive the initial phase, they still have chronic sequelae in the form of persistent dyspnea, syncopes, dizziness. They have permanent problems going on. So why do we need new treatment options in pulmonary embolism? Because we need to reduce their mortality, which is still very high. High-risk P, mortality is 63%. Intermediate high-risk patients, mortality is around 25%. And we need to reduce their morbidity, which are the long-term sequelae. So just to give you a case that I've taken from the West, just to show how things are being managed there, 67-year-old gentleman with 12 hours history of worsening dyspnea. He had adenocarcinoma, operated, and was on chemotherapy. Heart rate is up, blood pressure is still stable. Saturations are down, respiratory rate is up. He's got the typical ECG pattern, typical severe overload of the right ventricle on echo. He's got a saddle embolus sitting in the pulmonary artery, bilateral emboli. RV is enlarged. He has a PESI score of 2, and he's intermediate high risk because his blood pressure is still stable. So as per guidelines, you can give him lytics, you can give him anticoagulation. The patient did not improve despite of 12 hours of treatment. Important thing is his blood pressure is still normal, but his lactate levels were going up. So if the lactate levels are going up, that's a very bad prognostic sign, even if the blood pressure is normal. They took the patient to the cath lab, did pulmonary embolectomy, and there was immediate response. You can see immediately post-procedure, the respiratory rate, heart rate, saturations, everything stabilized. His troponins, BNP, and lactate levels dropped down to half immediately after intervention. So now there are 2 devices that are approved for mechanical thrombectomy in pulmonary embolism. One is this AI-based computer-assisted vacuum thrombectomy, where they have this color light system where once you take your catheter to the clot and it has sensed the clot, it tells you to start aspiration. And once it has aspirated the whole clot, the light again turns, changes color, and it tells you that it has aspirated all the clot. It does not want to waste the blood that you keep aspirating out. So this is AI assisted. So all you have to do in this is you take your normal J wire into the pulmonary artery, take a multipurpose catheter, exchange it to an implant super stiff wire, and you take the catheter in. Once the catheter reaches into the pulmonary artery, this catheter then no longer requires a wire to change its shape. You can change the shape and maneuver it wherever you need to take it. So you go onto both sides, you can see how the catheter is being directed upwards, downwards. You can change it the direction as you like. So this is the penumbra system that I just showed you. And that's the clot that came out. The other device that has been approved is Inari. This is the flow retriever system. So you can see there are 3 catheters shown here. One is a 24 French catheter, which is for the main pulmonary artery. Second catheter is a 20 French catheter. If you need to go distal beyond the main pulmonary artery through that 24 French catheter, this is a longer length 20 French catheter, and it has a curve there so that you can take it wherever you like. If you need to go still further distal, there's a third catheter, which is a 16 French catheter that goes through that 20 French catheter, and it is longer in length, so it goes and reaches wherever it is required. Once you've done all of this aspiration, if still there is some clot residual over there and you need to pull it out, it has got other devices with it, which are like, you can see that device there, or they've got discs which scratch the clot and bring it out. And what you see at the bottom is the flow saver. So the blood comes into this flow saver, it retains the clot, and you give the remaining blood back to the patient. So they don't want to waste blood. So this is how it works. This is the retriever system, and these are the discs that come with it. If the aspiration is not successful, then you can use these. So you've just taken this reaches up to the clot, and then you remove the dilator, you put the manual aspiration. This does not have an AI-based vacuum aspiration computer assisted. This is manual aspiration. You remove the clot, and once the clot is done, if there is still remaining clot over there at the same site, then you need to bring in those discs to take the clot out. The benefit is no lytics given, so no chances of intracerebral bleed. There is no chances of, you've left nothing behind, so those chronic sequelae and everything, the chances are really reduced. So you will see the clot being removed now. So these discs even come in different shapes and sizes. So this is how they make the drawings, and they've planted the clot over there to show where all they have extracted, and you can see how quickly the parameters have improved. So do we have data behind all of this? So now this is USA data flash registry of 800 patients, and what they've shown is they've included 8% high-risk Ps and 77% intermediate high-risk Ps in this group. The MACE was 1.8%. There was 0 device-related complications. And the other thing to be seen is, you can see here in this pink bar that the supplemental oxygen saturation pre-procedure was required in 90% patients. It dropped down to 28 after the procedure. The need for medical ICU was reduced to 1 day. And in 60% patients, they did not even need an ICU care, and in 3 days was the median time after which the patients were discharged and they went home without any sequelae. This is Flash Europe registry, had 40% high-risk patients. Interesting thing to see over here is 35 minutes procedure time. 35 minutes procedure time, and you are done with pulmonary embolectomy. The reduction in mean pulmonary artery pressure, the RV size reduces immediately, 1.8% MACE even in this European registry, and the dyspnea score has really improved. FLAME study, another big study going on, and it was stopped prematurely. Why it was stopped? Because look at this, in the FLAME group where we used the flow retriever, the mortality and MACE was 1.9% versus the other group which was conventional management, and it was 28.5%. There's a STRIKE-P study going on of 600 patients. The first 150 patient results that have come out are again positive in favor of doing mechanical thrombectomy. Ongoing trials, STORM-P trial, 100 patients, Peerless study, which is on 700 patients. Peerless 2 randomized control trial is enrolling patients now in US. This is 1200 patient study going on. So the guidelines haven't changed as yet. The new guidelines are about to come out, but this is a consensus paper that has come out recently. You can go through that. It gives the role of mechanical thrombectomy. So just sharing the algorithm that is being followed by the West, where they have mechanical thrombectomy facilities available. So if you have a patient with RV dysfunction, raised biomarkers, then you need to see if he's hemodynamically, blood pressure is stable or not. If the blood pressure is not stable, he falls into the high-risk P group. If you have a cath lab and mechanical thrombectomy service available, he just goes for mechanical thrombectomy. There are no lytics for this patient. If you don't have a cath lab facility for this patient, only then the patient goes for lytics. If the patient does not show improvement in 2 to 4 hours of lytic therapy, patient needs to be shifted to a service where they can do mechanical thrombectomy. In the intermediate high-risk group, The pressures are stable, but if the patient has high lactate levels, he has got tachycardia and other features that are given in the box, he still goes for mechanical thrombectomy, no latex for him. If he does not have these features, then he goes for anticoagulation therapy. And if within 12 to 24 hours of anticoagulation, the patient is still stable, but the parameters are not improving, he still goes for mechanical thrombectomy. So, coming to the last slide, there are 3 life-threatening blood clots. STEMI, we used to treat them with latex, now we do primary PCI. Acute stroke, we used to treat them with latex, now we do mechanical thrombectomy. Pulmonary embolism, we used to treat them with latex, we are still treating them with latex, but the paradigm has changed. The West is now moving towards mechanical thrombectomy. The evidence is there, and I'm sure the guidelines are going to change very soon. So with everybody sitting here who matters, I think this is an area we really need to look into. Thank you very much.
Question answer session will begin now. If there are any questions, you can please take.
Thank you. I think we'll start with Ali Raza Sahab.
Sir, thank you so much, and I'm glad you have taken it on board because I know that stroke you took and now pulmonary embolism as well. So,
Mike is not.
Achha, sorry. So I'm glad you have taken it on board because I know that you will take it somewhere from here. Pulmonary embolism, we tried it as well, and we wrote to a few people. We wrote to Penumbra, we wrote to Anari people as well, and I think the catheter, the costs, we look at the costs as well, because I know in Euro PCR, we went on these booths and looked at it. I think it's a very well required. The only thing is about that the companies, we need to convince someone to get these catheters down, because in my understanding, Anari is the best system for it at the moment. What do you think, which devices are the best for it at the moment?
So the data is positive for both of these devices. The only thing is, the biggest catheter that Penumbra still has is a 20 French catheter. Whereas with Inari, they've got a 24 French, and then they've got those devices also with which you can really take it out. So I looked up the costs. So in UK, this Penumbra system for one patient costs, for the disposables, it is £4,500. And disposables for one patient with Inari is £6,000. So the costs are still high. They are in real big demand now in the West. And I think soon, we will also move towards that side, and the cost probably will come down. PIC doesn't have cost issues. Yeah, sure.
Wonderful. Great talk, Asim bhai, and very well scripted. You really had our attention all the way. But for the time being, like you said, we just give the heparin and so on and so forth and wait it out. The perfusion catheter, when you give it and you ride it on the wire and in the middle of a thrombus, and you infuse it with the TPA, TPA is now very commonly available. We should not consider it as an expensive or rare drug. If given in infusion care 24 hours, they've shown that it dissolves everything. And so I think for those of us who do not, I think it will be some time before we gain access to it. But perfusion catheters are available. Yeah. So having a perfusion catheter, infusing TPA in the middle of this thrombus is very effective, and people have shown that also. So while we're waiting for this wonderful device to happen, that is an option we must all think of.
The question on that trial was this, that the mechanical effect of the catheter actually causes more advantage than you giving the TPA at the exact point there, because I was present in that discussions, and they said that it's usually when you reach the catheter there, you usually use a catheter, you cause some disruption there actually. And then the cascade mechanism of it works later on. So advantage wasn't that clear whether it's just pure the thrombolytic. Obviously there will be advantage of it, but the mechanical effect of it as well.
We're talking about different things, like no mechanical thrombectomy has shown evidence of, at least in coronaries. But people try to use the same device in the pulmonary. And that's where that data was brought up, that there was disruption by the device. But this totally, just put the wire in, push the perfusion catheter, and it's so simple as that, and attach a perfusion, the infusion pump, and that's how it all works. No, you're not aspirating. You're infusing. You attach it to a infusion pump and infuse PTA, TPA in middle of the thrombus, and it dissolves it away.
Sir, thank you very much for a wonderful talk. Sir, just wanted to ask that does these catheters have a role in IVC thrombosis, extensive IVC thrombosis who have not developed pulmonary embolism yet, but who are at high risk of developing pulmonary embolism, like we see cases of extensive thrombus involving the renal veins and the IVC. Are they can be used in such cases, or just they should be treated with the anticoagulants or in situ lytics, as General Sohail Aziz had
So
pointed?
for DVTs, for IVC thrombus, there are other devices also that can be used. You've got angiojet that can be used. There are many other devices that can be used. But for pulmonary embolism, previously angiojet was also being used. Now it's not licensed for it anymore. These are the only two devices licensed for pulmonary embolism. On the way back, what they've done is, on the way out, if there is extensive DVT or IVC thrombus, they do remove it with these catheters on the way out. They're using it for this purpose. But dedicatedly, it's for pulmonary embolism.
So one more question. I really appreciate for the excellent talk. I want to ask, suppose we are seeing all the things in the right now videos not available in Pakistan. What do you think about very small size thrombus present either in the saddle branch or in the some part ahead, about choosing the intracoronary thrombustor in case we can just track the things out, whether it will help or not, or have you ever experience with it before?
The use of thrombustor in pulmonary embolism?
Yeah.
So that's heavy clot burden sitting there. Even for stroke, the coronary thrombustors don't work. Coronary thrombustor is only good for the coronaries. You can't extract anything else, anything bigger in DVTs, Ps. It doesn't work. It's too small a catheter. So that's a 6 French catheter. But what they've seen benefit with is 24 French catheters, 20 French catheters. So 6 is, again, very small for it.
Sir.
It is a venous access.
Sir, we at AFIC Cardiac Surgery Department, we had a patient with chronic thromboembolic pulmonary thromboembolism, and that was a very young patient at 27 years of age. In our management and in our scoring system, we never talk about the left ventricular function. That patient has a very poor LV with 15 to 20%, in addition to the all the compensation and decompensation on the right side. We proceeded with surgical thromboembolectomy of that patient, and we had everything, ECMO and everything. I think there are many other aspects. We don't have much data available. We are still quite... I think we need more time and more data should be collected, especially for the post-operative management of these patients, whether we are doing it by mechanical thromboembolectomy or by surgical thromboembolectomy.
So this is an upcoming specialty. Yeah. You will see more and more data coming in. Large trials are being done, 1,200 patients, 1,500 patients, randomized controlled trials, because the initial trials are really positive for mortality and morbidity in pulmonary embolism.
So
You'll see more data.
Any scoring system on the left ventricular?
The current scoring systems don't involve it.
They don't involve it. Thank you.
Sir Asim, a very excellent presentation. I have a question for you. Is there any case reported for fat embolism and amniotic fluid embolism, because we cannot give thrombolytics in those cases?
With these devices, no. These are dedicated thromboembolic devices.
I definitely support in what you said, and I get report cases from my son who is teaching me cardiology now, that he has used both in penumbra and NRE. And when he uses in the cases, the amount of clot it can extract is tremendous. So there are cases in which heparin will be good, there are cases in which thrombolytic will work, but then there are cases which we lose perhaps in which NRE or penumbra, and perhaps these both are complementing each other. So most centers have both of them. And in US, they don't have problems because those machines are brought in by the reps, but we probably have to procure it, and definitely we have to go this way. Thank you very much.
Thank you very much, sir. Thank you very much, everybody.
Thank you very much. I think there have been very excellent presentations and wonderful discussions, and at the same time, I think this kind of thrombectomy, this is very, very fascinating, but at the same time, it's very costly. So I think considering the constraints of the economy, I think we'll go for these kind of intervention and the devices in future. Once I think each of major centers in every province should have this kind of facility with them available, because it should be available. If someone, the head of state or someone else comes and visit Pakistan, and if he has this kind of a problem over there and you don't have this facility, then you're gone. So I think we should have it, and hopefully at the next financial year, they will have the kind of a budget where they can, I think, fund us for these kind of facilities. Thank you. We are already late for the lunch, so let's go for the lunch and prayers. Thank you.
Assalamu alaikum, distinguished guests. I just want to inform you that our next session on the structural heart diseases will commence at 3 o'clock, please. Thank you.